Hi, my name is Mairéad Loftus and you are very welcome to our Inclusion Health podcast series. This is part of a continuum of Including Inclusion Health Voices from the Margins webinar series that we did earlier this year. This is episode 1 and I'm joined by Sharon Lambert. Sharon is a senior lecturer in applied psychology in University College Cork. And Sharon's research interest areas are trauma-informed service design. Sharon, you are very welcome. And we spent long hours talking about this subject. For our audience today, can you tell us what your meaning of trauma-informed design is?
So the idea of trauma-informed design really originated in homelessness and addiction services in the States. So anybody who's ever worked in homelessness and addiction will know that you have profiles of people who come through the door, and it's sometimes, a different face, but a very similar story. And one of the things that's very obvious is that people who are on the margins can be very, very physically ill and psychologically unwell, and they really, really struggle to access and use services. So a lot of the time when we design services, we design them for people who are functioning quite well. And then that means that there's this really big cohort of people who really, really need access, who can't use them in the way we've designed them. So trauma-informed design thinks about the science of stress and the science of trauma. So the impact of stress on thinking and on behaviour. So how it affects memory, how it can affect emotional regulation, how it can affect the way people can perceive, body language, or somebody comes to your service and you're in great form, but there's something about you that triggers some kind of stress response in them, and then what that looks like. And sometimes trauma is messy. Often trauma is very messy. People who've experienced a lot of trauma can be very, very distressed. Some people would describe them maybe as challenging. If we reframe that and we think about them as being emotionally dysregulated, and we incorporate all of that science into how we design and deliver our services, then it should have a better impact for patients and for staff.
I'm thinking as you're talking there about the person that's presenting to the service in the current climate, our staff have come out of a very busy time and a very stressful time. Where does that sit with them, or does the research say anything about where that sits with them? Are they ready to actually take that view of the world?
So trauma-informed services not only think about the trauma and service user, but they think about the impact of that on staff. So there's loads of data on secondary traumatic stress in frontline providers. So, COVID was very, very difficult for a lot of frontline workers. And as well as that, we have our own data from frontline workers that shows that lots of frontline workers have experienced their own traumas, their own personal traumas outside of work. So sometimes you can be going into work and the tank is kind of empty. And then you're meeting people who are really, really stressed. And you can have two stressed people in the same environment, and that never ends well. So a trauma-informed service thinks not only about the service user, but about making the service safe for the staff as well. So I'll give you an example. I was driving somewhere one day and they were talking about the increase in abuse towards staff in accident and emergency. And there was a consultant on and he was saying we need to fine people. And the reality is that that's not going to work, because if somebody's emotionally dysregulated, their prefrontal cortex or their thinking brain is not fully functioning, it's gone offline. So if you have signs all over the place saying that you're going to fine somebody, it's going to make absolutely no difference. They're going to behave like that anyway. And when we become more punitive, it makes people more aggressive. And then it's the staff who are on the floor who have to deal with that. So if we have services that are the opposite of punitive, then that helps to regulate the service user, which means it's much easier for the staff. For example, we did a study a couple of years ago. Donald Moynihan was doing his doctorate in clinical psychology, and he spoke to young men who leave A&E without being seen after an episode of very serious self-harm. And sometimes they'd kick off before they left. And for them, what was really interesting was they'd be really, really distressed and really, really suicidal, and then the ambulance would come. And the paramedics would be really kind and gentle, and they would immediately feel better, like they're going to be safe and it's going to be okay. And then they'd arrive to A&E and a security guard might look them up and down because they might be dishevelled. And they have really low self-esteem. And their immediate reaction is to feel combative. And then once they're in that zone, they start to interpret a whole load of meaning. So, I've small children, I've been to A&E loads of times. And when people are really busy, the way they rush through and they try not to make eye contact in case you're going to stop them and ask them, and they just don't have time. So I know that when I'm sitting there, because I'm doing okay, so I'm sitting there and I'm going, oh, look at your one now, trying not to look at me in case I ask her a question. Whereas if I'm somebody who already feels worthless, I interpret that as I'm not good enough and people don't like me and people don't want me. And that's exactly what they interpreted it as. So then they would, just disappear without telling anybody, or else they would argue with people and then leave. So there's small things we can do when we think about how traumatised people come to use services. There's small things that we can do as organisations that reduces the way they are distressed, which then, of course, makes it easier for the staff.
And now that you mentioned small things, because it's good to hear small things, because I don't think sometimes in the service we're ready for big change. But what are the small things that would help?
One of the first things is a basic level of trauma awareness across all staff. So often when organisations think about trauma awareness, they think about the clinical staff. And in all of the different projects that we've done, actually, it's the first point of contact is the problem sometimes. So you have to have everybody trained, security, administration, cleaning, anybody who's walking in and out of the building, to know that if you just smile and look at somebody, that in itself will help reduce somebody's stress, which makes them less likely to kick off. And I know I've worked in services. I know what it's like to walk through a waiting room as a staff member when you're really busy and be afraid to look at somebody in case they want something from you and you've nothing left to give. But if you just look and make eye contact with somebody and smile, that can make a huge difference. Because one of the big findings that came out of that study with Donal Moynihan was, I think the title of the study, the paper ended up being Hiding in the Shadows, because people felt unseen. And when people feel unseen, the brain interprets that as danger. And then once you are in a dangerous situation, it's science, it's stress 101. Your fight or flight response system is activated. So people either disappear or they argue with you. And then we blame them.
It's true, actually. Yeah, you're quite right on that we do blame them.
Yeah.
All we see is the behaviour.
Yeah, so we blame them for doing something that's an automatic response. And I mean, I'm a parent. I've been to the hospital and I've been frightened when I've been there with a small baby. And I have not always behaved the way that would have been totally acceptable and in line with what people would want. And it doesn't mean that I'm in that moment when I'm cross and I'm given out. It's not because I'm a bad person. It's because I'm frightened. And my brain knows that I'm frightened and it's doing exactly what it's supposed to do when I'm frightened. But on the outside, people are going to look and they're going to say, oh, she's crazy, she's out of control, or she's difficult, or she's challenging. But she's not. She's frightened. And that's a small thing we can do, actually, is change our language. How the words that we use to describe people create an impression of how they are or how we expect them to be. And if I see somebody who's angry, for example, I might say, I wonder why they're upset. And if I think about anger as being upset, it might change the way I feel about that person.
When you say what language is important, what comes to mind for me is the way we label different people that present to services. We've automatic labels. It's not intentional, but I probably feel it's the way the service has been built. So is that what you're talking about when you're talking about language? Are you talking about the language of compassion and kindness, or is it both?
Yeah, so it's both. So a trauma-informed service challenges stigmatising language. So, Mairéad, you and I have spoken before around addiction is a good example. Yeah. So if you say, Sharon Lambert is downstairs in A&E and she's an addict, that's not somebody's whole identity. But if that's the word that you use about them, it conjures up a whole host of pictures or expectations. One of the things I suppose I'm fairly passionate about is that use of language and how we can create a picture, because it's something we do in psychology all the time. There's lots of labels in psychology that I think are quite damaging. And the question I always say to myself is, has that word increased somebody's social inclusion, or has it made them more socially excluded? So words like addict make people... I have a child who has a lot of hospital visits. I'm fairly certain it says somewhere on her file, challenging mother. But maybe I'm not a challenging mother. Maybe I'm an advocate, because that's what I'm supposed to do as a parent. So you could look at me and you could say, Sharon's a total dose, or you could say, Sharon's a great advocate for her child. In psychology, some of the terms that have been challenged are words like borderline personality disorder, conduct disorder, and oppositional defiant disorder in young people. So do those words make people more included or more excluded?
From my experience, it probably makes staff more cautious. So if you're more cautious, does that mean that they're excluded? It's a good, actually, premise. It's a good question.
And it's interesting, because I was talking to somebody about this the other day. If you take homelessness, for example, and we talk about people who are experiencing homelessness and what we might think, what words or feelings or pictures come into our head. And I experienced kindness at the train station recently in Dublin from somebody experiencing homelessness, a lovely young fella in a really, really difficult situation, and he's using crack cocaine. He had been assaulted, and it was obviously been assaulted, and he'd spent the night in the hospital. But he was lovely, and he was really, really kind. And I could see how people were looking at him when they were walking past, and he could see it too. And it was interesting to watch him, because as he moved from person to person asking for money, it was almost like he was getting physically smaller. It was almost like his body was shrinking. And he started off with kind of a voice of desperation when he was asking for the money. And as he moved through the people, by the time he got as far as me, he'd moved from desperation to frustration. So he might have looked to some people as cross, but he wasn't. He was in his boots. And we had a chat, and he was really nice. And I got on the train, and something that was interesting to me was when I was on the train, he'd fabulous manners. That shouldn't matter, but I suppose it was something that struck me about him. And when I got in the train then, I saw loads of very well-dressed, very well-spoken people. And the trolley cart was coming, and the lady was serving tea and coffee. And I noticed how many of them didn't use their manners, and how many of them got off the train without clearing up their mess after them. And I thought, when we see him, that guy at the train station, all we see is the situation that he's in now. But what you don't see is that he was a really, really nice young fellow with really fabulous manners who's in a really difficult situation. And I've met people who are not in difficult situations who don't have the same capacity for compassion and kindness and general respect that he had.
Do you think that his capacity for kindness and compassion comes from the challenges that he's had, and because he's in that situation, he's viewing life from a different viewpoint?
Yeah, because when you talk to people who use drugs or people who are in homelessness, they describe it as a community where they do look after each other. There can be significant violence in that community, but there can also be significant care and compassion. One of my PhD students, Daniel Callahan, has just finished a research project where he interviewed people who had lost a friend as a result of a drug-related death while they were in active addiction themselves. And what came out really strongly from the data was a kind of a shared sense of community through adversity. So many of them had walked the same path. So they recognised the pain in each other. And they understood that they had to do things to survive. And they helped each other because they were on the margins. And even when their friends or loved ones died, those deaths weren't respected because it was seen as, oh, it's your own fault, you died by drugs. So like they live in the margins, they grieve in the margins. And then when we interact with them, they don't always feel included.
Is it that they don't feel included, or it's a lack of trust?
Well, it's both. I always say to people, if you want to really know how your service works, go and sit in the waiting room with somebody who is really, in their boots. I, have worked in community services myself, so I have gone to attend various different appointments with people who were really struggling. And it's interesting the reception I might get when I'm on my own versus the experience for this person that I'm with, and it starts sometimes before you even arrive at the building. I think the travelling community is a good example. I spend a lot of time with the Traveller Visibility Group in Cork, and I have some very good friends there, an amazing group of traveller women. And every week, at least one of them will have had an experience where they've been followed around. These are all women who are healthcare workers, and they're getting up in the morning, they're going to work, and they go into the shop and they're followed around. Or somebody passes a smart comment when they're filling up their diesel or something like that. So if you're giving somebody from the traveller community an appointment, it's not even just about how your service has treated them. It's from the minute they leave their house until they come to the service, how many people have treated them like they're not good enough along the way. And I know if I got up in the morning time and I had to spend so much energy planning my route, that's what they do. They plan their route to try to avoid being made to feel less than. If I had to experience as much discrimination as they do, by the time I'd come to your service, I'd be fairly cranky too. And if you were having a bad day, Mairéad, will say, if I went into your service and you were having a bad day and I asked you a question and the answer was a bit short, I might say, God, your one's a bit, she's very cranky today. I won't internalise it as being about me. But if I've had 5 or 6 people treat me like that day, I'm not going to think that, oh, you're having a bad day. I'm going to think this is specifically about me not being wanted here. So we have to be able to imagine what it's like to walk in the shoes of another. And if we can't do that, then we also have to ask them what it's like. And we have to be able to hear it. And if you don't have difficult conversations, then you're not really talking about trauma. So if somebody says to you, your service isn't good because, and if your immediate reaction is to be defensive, then you're not going to be able to be trauma sensitive because you're not prepared to have difficult conversations. We all make mistakes.
I'm just thinking there when you talk about the traveller woman, you know, that she leaves the house, she's employed as a healthcare worker, coming into work. And I'm also thinking of one of the lived experiences that we had on the Inclusion Health webinar series, which was that word recovering addict, which following my chats with you, I'm not very comfortable with anymore. And they talked about that as well, that once somebody, you know, became familiar with their story, not the backstory, but the story that the public likes to see. Can you really develop a trauma-aware service that includes the voices from the margin if we don't look at it from a societal point of view?
Well, I mean, if you really want to have a trauma-sensitive service, we would have everybody working in them. So we would have, for example, traveller psychologists, traveller nurses, traveller doctors, because we did a project in Cork with non-travellers who work in healthcare services, and they had very high levels of bias against travellers. So when somebody doesn't turn up for an appointment, assuming it's because they don't care, when actually they have turned up, but they were treated really badly in the waiting room and they left and you didn't even know that they were there. So they undertook traveller cultural awareness training and their level of traveller bias decreased. But 7 months later, it was back up again. So the only way that you will ever be able to challenge stereotypes is if you are working with people who are from various different communities. Because, you know, if you take the health services, for example, I mean, you're not making wedding cakes. So often when you see people, you see them at their worst. You know, so your only experience of a particular type of community, whether it's somebody who uses drugs, somebody from homelessness, somebody from another minoritized group, you are only seeing them when they are at their worst. That's your only frame of reference. And when somebody says to me, oh, travellers don't behave or whatever, I've often misbehaved when I've gone for medical appointments because I've gotten cranky and hungry and frightened and frustrated and all of those things. But people meet me in other contexts. So then they can go, oh, you know, she had a bad day. Whereas if we only meet people in one context and we never see them in another, we'll never really challenge our biases. So for a truly trauma-informed service, it needs to be inclusive. It can't be this charity model of handing down to people all of the time. We need to be lifting people up. We need people with lived experience working in all of the different roles. Otherwise, we are middle class, settled, white services, and we can only design those services for ourselves because we couldn't possibly know what it's like to be from another community.
You know, when you look at some of, you know, the Child Centre in Harvard, there's one quote in it: are we telling people to drag themselves up by the bootstraps, or are we actually giving them the scaffolding to help them, you know, move forward? When you're talking there about the different services, we're now moving into a new stage in the health service. As you know, the HSE has been reconfigured and we're looking at more integrated programmes. So I suppose if you were to give any advice to services, because a lot of services, particularly mental health services, are looking at the trauma aware model, what would you say to them?
Is that it can't be a charity model. If we look at people who've experienced trauma as being less than, then we're never really truly going to meet them where they're at, because we are seeing ourselves as better than. So everything should be co-designed. You couldn't possibly understand the challenges that people experience unless you bring them in to help them.
To design that.
Yeah. So like just simple things like, you know, the people might take for granted. One of my kids had an appointment one time in a hospital, and it was during COVID, so you weren't allowed in, and you just sit outside in the car park and ring this number. So I rang a mobile phone number 17 times, and the 8-year-old is in the back of the car. I'm going to wet myself. 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 And then, can I please go in the car park? No, you can't. You know, any minute now, any minute. So then I Google the main number, ring them, get put through. Turns out that the phone number that's on the letter hasn't worked in a very long time. And I say, okay, now inside I'm absolutely raging. But I took a deep breath and said I have to behave myself because that's what's appropriate. But I didn't have other pressures. So, for example, if I had somebody who was able to collect other children from school, I could afford to be hanging around, you know, in terms of the prices of buses or car parks or getting drinks and snacks. I didn't have massive pressures on my time that day. I had a whole chunk of time crossed out. If I'm somebody who doesn't have those resources and I'm really, really stressed, what's going to happen is I'm going to arrive in and I'm going to be really cranky. And people, instead of being curious about what's going on, will immediately say that it's me is the problem. And this isn't about blaming the service, because that was just a simple mistake. Mm-hmm. I don't know how long the letter had gone out. It could have been gone out 6 months. But instead of going, you know, why is she so cranky? Be curious as to why. And you'd say, look, I'm really sorry. I didn't realise that letter had the wrong number in it or whatever. But our desire to, when we're tired especially, and when people are cross, is to get defensive instead of to become curious.
Curious, that's a big word, isn't it? So is that curious from the staff perspective, but also from the person who's coming to the service? Or have they the capacity to be curious?
Sometimes they don't. Sometimes people are, I mean, if you think about what's going on, 1 in 5 children, their parents don't have enough money to buy them shoes. 1 in 5 children in Ireland.
Really, in the Republic?
Yes. The Children's Rights Alliance have their child poverty report out today. 1 in 4 people in Ireland are behind in their gas bills. So that financial pressures have a very detrimental impact on people's mental health. You know, so and you don't always know who's under financial pressure either. You know, that is across all of the
manicured lawns.
Yes, exactly. Yeah. So when people are coming to your service and they're difficult or they're challenging, it's about being curious rather than assuming that they are difficult and challenging. And because we never ever know what's going on in somebody's life. And there are lots and lots of people who are really, really struggling. Sometimes it's very obvious what the struggle is. The people who are very on the margins, it's very obvious what the struggle is. And if we are able to be curious about, one of the things I often think about is their lost potential. So what would they have the capacity to be if they were able to access the services that they needed? And it would make the world that we live in a much more pleasant world, because when people are well, they are less scary to others. They don't put as much pressure on the health system or the social care system or the justice system. So the way we do that is by having services that are really accessible and that people get what they want when they need it, and that they get well. And then when people get well, they give back.
That sounds like nirvana when you sit inside in the health service. But I'm going to come back to something that you said there. But you mentioned about co-design. And that's probably key here, isn't it? And oftentimes there's a fear from clinicians and practitioners to bring, I know my own experience, to bring the person who's coming into contact with the service into that co-design process very early. So how do you think we should go about that?
About having, there are loads and loads of community-based organisations where you have people who serve particular communities, and they are often from those communities as well. And there's a master's student, Anne-Marie Quilligan, who is a traveller, and she's just finished her master's, where she interviewed travellers who are healthcare workers. And one of the things that came up a lot was that there was a poverty, this is the term from her master's, a poverty of expectation. So that when people met traveller workers, for example, that there was an expectation that they were not educated, even though they all have degrees and some of them have masters. One of them has a PhD. But there was a poverty of expectation. There's a poverty of expectation from people who use drugs and people experiencing homelessness as well. And what you have is people who are exactly the same as everybody else. They just haven't had the same opportunities. So that's where the fear comes in. It's like, oh, I don't understand that community, or they might not be able, or they might be cross. That's kind of a bias, actually. People would have no problem bringing me in. Oh, Sharon, we want to design this. I don't have as much expertise as somebody who's experienced homelessness. So there's a bias that I have something more to offer than somebody else, when there's a bias about what their level of intelligence or understanding or insight might be, when that's not the reality. And that's really challenging.
That's really interesting. I'm just thinking, even, in the disability community and in the migrant community, the new migrant community that we have in Ireland, that they're often on, people are often on the fringes, and language is used as a barrier there, that maybe you can't co-design because you don't have the same language. I'm a bit stuck for words, really, when I think about that, because we do have a bias.
We do have a bias, but we sometimes don't even know we have that bias, because there's a conference on coming up soon, and it's a policy-related conference, and I sent the flyer for it, and every single person on that is a white middle-class person. There's no traveller, there's no migrant, there's no disabled person on that forum, and it's a policy conference. And I emailed them back to say, not sure whether you noticed, but they obviously didn't, so they haven't replied. But
But you're quite right, because unless you're inside engaging, how can you actually develop a service? History has taught us that in Australia and Canada and different countries.
There was a service in New Zealand where they built a community health care. I think you and me spoke about this before, Mairéad. They spent an awful lot of money building a community health service for Indigenous people, and they didn't use it. And it's because they hadn't considered what their needs were. It wasn't culturally appropriate. And then when they went back and said, why aren't you coming? There was a whole host of very practical reasons why they couldn't even access the service. And once they had done that engagement piece, I think, so their DNAs had been 60% or something. And then that dropped right down to under 10%. But it's even here, with the DNAs, we blame, if you're waiting for an appointment, people who are waiting for an appointment want that appointment. Why do they not come? Have they turned up and have they left? I know I've been down for a DNA because I went to the wrong hospital. One of my children had 3 different appointments because she has a couple of different things going on, and I made a mistake and I went to the wrong hospital. So I'm down as a DNA in another hospital. But we did turn up. We made a huge effort to turn up, and she was out of school for the day and all of that. So even that did not attend.
And you with the capacity to follow it up.
Yeah, but I'm still down as a DNA. That's what it says in the file, that we're a DNA. But we weren't really, and if I have, considering the privilege that I have, if I have the capacity to make a mistake like that, what is it like for people who are really, really stressed, who are under, really serious financial hardship, or they're in very difficult or challenging relationships, or they're struggling with their mental health? If I've made a mistake like that, that's not the only one. I turned up on the wrong day another day. I had written Tuesday in my diary, but it was actually on a Monday. So, how many people, we're not allowed to make a mistake, so you're punished then for your DNA, when actually that's okay. Like, people forget things, or they get the day wrong all the time. That happens. It's not the end of the world. It's totally human nature, but we have a kind of a punitive approach to it.
Sharon, thank you so much for joining us today. And we possibly will be back to you again. We're always back to you because you always have so much to discuss. I think somewhere along this series now we're going to have to talk about co-design. I think because the key message that I'm getting is that we need to look beyond what we see in front of us, and we need to engage the people who are coming to our service and actually talk to them and find out what they need from the service, not what the service needs from them. Thank you, Sharon.
Thank you.
It was lovely to catch up with Sharon again and talk all things trauma and inclusion. And I suppose my takeaways from today's episode are a smile, openness, kindness, compassion, and to look beyond the person that's in front of us and to hear their story, or to be curious about their story, and to bring and engage people at the start of building a service and not halfway through or at the end. Today's podcast was produced by Miss Annette Cuddy, Director of the Centre of Nurse and Midwifery Education, Mayo, Roscommon; Miss Cora Appelbe, Specialist Coordinator, Nurse Tutor, the Centre of Nurse and Midwifery Education, Mayo, Roscommon; Mr. Alan Meaney, Radio Producer; and I'm Mairéad Loftus, Specialist Coordinator, Nurse Tutor, Centre of Nurse and Midwifery Education, Mayo, Roscommon. We look forward to welcoming you to our next episode, and you can follow progress of the podcast series on X at CNME Mayo Ross.